Good morning. The COVID-19 pandemic is just the latest reminder that every decade or so a disaster hits the U.S. that obliges many families to turn to government safety, social safety net protections. But what if there were a better way to help families protect themselves from life's risks than what we now call our social safety net? What if that way did not require bloated government bureaucracies, increased taxes, runaway spending, and debt? Independent Institute Senior Fellow John Goodman has forged just such a path, and we'll discuss this with him today in our Lighthouse Briefing from the Independent Institute. I'm Graham Walker, and I'm coming to you from the Independent Institute in Oakland, California. We're just across the bay from San Francisco, and we're delighted to welcome everybody to our Lighthouse Briefing today. We invite members of our Lighthouse Society to these briefings, along with a few select friends, to get you a front row seat, a private skybox, if you will, as we launch new policy initiatives and books. After all, it's our members who make all this possible. So I'm pausing here at the start to thank our generous friends and, of course, to invite you to extend your support as we continue to make an impact. Remember, you can always go to independent.org for our policy resources, plus to donate. There's a donate button at the top right of our main webpage. During today's briefing, we want you to offer some questions and comments to our guest, Dr. Goodman. And when I get to that point, I'll remind you of this, but all those who are on the webinar with us this morning, you can put your questions in the chat at the bottom of the Zoom, or you can well, not literally, you can use the icon to raise your hands over in the participant panel. And when you raise your hand there or in the bottom, I'll see your hand being raised. I'll open up the microphone, and you can actually ask a question yourself. So let me turn now to our guest this morning. Let me welcome Dr. John Goodman, author of the new book, New Way to Care, Social Protections That Put Families First. Welcome, John.
Glad to be with you.
It's a pleasure to have you. John Goodman is a senior fellow here at the Independent Institute. He's also president of the Goodman Institute for Public Policy Research. He's been featured in the Wall Street Journal, National Journal. Others have called him the father of health savings accounts, which was a big policy boost to many Americans for their health care. He's been testifying before Congress. He's offered more than 50 studies on health policy, retirement reform, and tax issues, 10 books. Your latest book, John, is the one we're talking about today, which is A New Way to Care. And just giving people a quick look at the cover, you can order this through Amazon, but if you are in fact a member of our Lighthouse Society and have opted in, those books are actually being shipped to you right now as we speak. You'll be getting it right away in the mail, probably early next week if you haven't already got it. This is an interesting book. It's a very timely book. It could be overshadowed by other news this week, but I think, John, that it's really likely to take center stage in policy debates during this first year of the Biden administration, don't you? Or at least it deserves it.
Well, I agree. It does deserve it. Hard to argue with that.
We'll see what actually happens. But, you know, the subject is not going away because the crises are not going away. And the current crisis, I mean, the COVID-19 crisis in particular, seems to be shedding kind of a torch on a lot of the problems with our social safety net, not just healthcare. What has COVID crisis taught us about some of these difficulties with the rest of the safety net in addition to health?
Well, a lot. And the interesting thing is this book was almost completely written before COVID came along. But what COVID did is it exposed some big flaws in our safety net institutions that people would otherwise not even be aware of. So let's take the big three: Medicare, Medicaid, Social Security. What do we learn about Medicare from COVID? Well, when COVID struck, believe it or not, I have my cell phone with me. It was not legal for a doctor to bill Medicare for a consultation by phone or by any other telehealth
They
device.
had to go in person.
Yes, you had to go in person.
Ah.
And that was a law of Congress. And by the way, that law would still be on the books if it weren't for COVID. So what happened was Congress got scared. They passed some emergency legislation. The Trump administration had been fans of telehealth for a long time anyway, and so they were ready. And so they already had 145 different doctor tasks that they wanted to approve for telehealth. And so there you have it. Now, seniors are the least computer literate of any segment of our population. But by April, 1 in 5 in the rural areas and almost 1 in 3 in the cities had at least one telehealth visit. So that's rather incredible.
So old dogs can learn new tricks after all.
Yes, and remember, I just want to repeat again, had it not been for COVID, you still wouldn't be able to talk to your doctor by phone, at least, and have Medicare pay for it.
Mm-hmm.
And then Medicaid, I think it's more than 40% of all the deaths by COVID have been in a nursing home. 60% of all nursing home costs are paid for by Medicaid. Among the countries around the world, we're one of the most institution-bound countries that there is. In most European countries, they don't put everybody in nursing home. Well, what happened when COVID came along? Nursing homes turned out to be really dangerous places to be. One person gets the virus and then spreads it all over the place, and we have a lot of people dying. So that tells us something is wrong with the way we're taking care of seniors. And then Social Security. Well, a lot of people lost their jobs this past year, and a lot of those were older workers. And some of them decided, well, I'll just retire early. But here's the thing, a senior who's retired early, claiming early Social Security benefits, if that senior takes a part-time job because they need additional income or even some other kind of job, once they get above about $17,000 of income, they start losing 50 cents of Social Security benefits for every dollar that they earn. And when you add that Social Security benefit tax on top, of the Social Security benefit tax, the income tax, the payroll tax, a part-time worker who's a senior citizen receiving Social Security benefits can be in a 95% income tax bracket. And most people wouldn't know that, but COVID has just put a lot of people in a position where suddenly they're going to become aware of it. And also, seniors are going to become aware of the fact that when they claim early benefits, they lose out on the ability to see their Social Security benefits grow at a substantial rate if they would just put it off until age 70. Now, if you go to the younger population, what we discovered is that the younger people could use the phone. In fact,
they were more apt to do so because they kind of understood that.
Well, we allowed it.
And we allowed it because they weren't on
Medicare,
right?
we didn't have a law of Congress say you can't do this.
Right.
And so it was part of a lot of employer plans. And Teladoc here in Dallas has 20 million customers.
Wow.
And these are people who can call a doctor anytime, day or night, and get a prescription filled and get other medical advice. And but what couldn't they do? They couldn't do what we're doing right now. They couldn't use Zoom. They couldn't use Facebook. They couldn't use Skype. And why? Because this violates the federal privacy regulations. So even young people were greatly hampered by ridiculous federal laws. Well, again, all of that has been set aside again as an emergency.
Yeah.
And we'll come back to this, but I just want everybody to know that your newfound freedom is tied to the virus. And when the virus goes away, this freedom goes away unless
Congress wakes up. Yeah.
Exactly, and makes it permanent. And that's one of my goals for this year is to try to get that done.
You talked about how the COVID crisis has illustrated weaknesses in healthcare provision, on Social Security. How about unemployment?
Well, what we discovered is that our system is not ready for this, and so not knowing what to do, we wrote big checks, and turned out that about 70% of the people getting a check were getting more from the government than they were getting from their job, and so we were discouraging people from going back to work. Now, just back to the employees for a moment who are getting insurance from an employer. This is a time when you really want to be able to have a phone conversation with a doctor or a Zoom conversation at nights and on weekends, because if you can't do that, then what's left is the hospital emergency room. Well, those are dangerous places to be.
I don't want to go there right now.
Exactly. So, but the employer, again, another big defect in the system, the employer couldn't put money into an account so the employee could have a relationship with a doctor. We used to call it concierge medicine.
Right.
And now it's called direct primary care. And what that means is...
Concierge sounded snooty.
Yeah, well, it was kind of snooty, and you had to pay a lot of money.
Right.
Let me tell you, the cost has come down though. A mother with a child, the mother pays $50 a month, $10 a month for the child, and for that, she has a doctor's cell phone number. She can talk to the doctor at nights and on weekends. She gets all her primary care, and a lot of these relationships allow her to buy generic drugs at less than what Medicaid pays. That she can get discounts on lab tests, and so it can be a really good relationship. Very, very important in the face of COVID because the mother doesn't want to take her child to the emergency room. And one other thing that's very important that happened this year, before the year 2019, it was illegal for an employer to buy for the employee insurance that the employee owned and could take with them from job to job and in and out of the labor market. Well, think how many people lost their jobs last year.
Right.
If they could take their insurance with them, then they don't lose coverage just because
This is called portability. Is that what it's called, John?
I call it personal and portable health insurance.
Yeah.
And think of Blue Cross for a moment. Blue Cross comes to the employer. They can only sell group insurance, but we know that Blue Cross has individual policies, but the employer can't buy the individual policies. You can only buy group insurance. If you're an employee, you lose membership in that plan when you lose your job. So last year, starting January 1st, for the first time ever, really, because of the Trump administration, employers are now able to give their employees pre-tax dollars so they can have their own insurance. The employee can choose the insurance and take it with them from job to job, in and out of the labor market.
So that's like a different, when they leave their employer, it's like a variation on the COBRA scheme because they can take it with them if they keep paying the premiums, right?
Yes, it's better than COBRA.
I was going to say, it sounds way better than COBRA.
Yeah, well, it is because you own the insurance. You've already locked in what the premium is going to be.
Oh, at the group rate?
Yes.
Uh-huh. And this is so puzzling to ordinary people like me. Like, why would it have been considered a good idea to prevent employers from being able to provide portable insurance to their employees? Why was that against the law or policy or regulation?
Well, it was always suspect. And because it was suspect, a lot of employers, before the Obama administration, before we had Obamacare, employers were doing this, but it wasn't clear that it was legal. So a lot of insurance companies had a don't ask, don't tell policy. So when the insurance agent sold a policy to an individual, they were not supposed to ask if the money is really coming from the employer. And if they knew that, they might have to turn the request down. But then Obama came along, and they were afraid that people would leave the employer market and go over to the Obamacare market and get subsidized coverage. And so they made a very, very strong ruling that if an employer was caught doing this, they could be fined $100 per employee per day.
Oh, my goodness.
$36,500 a year per employee. So that was the highest fine in all of Obamacare. So they really didn't want this to happen. Trump completely reversed this. And by the way, all this is being done by executive order. Congress has never weighed in on any of this.
Right,
This is Obama doing his deal by executive order, Trump reversing everything by executive order.
And then just parenthetically, this illustrates a major problem with our current politics, whereby Congress doesn't step into its jurisdiction, but kind of abandons it to presidents, and they do their executive orders, and we get these flip-flops.
Exactly. Now, when Obama was president, a lot of Republicans complained that he was abusing his executive authority. Well,
I remember.
Trump did a one-up on him. Trump was just as bad.
But the Republicans seem to be not so unhappy as they were before at the use of executive orders.
Well, I would say that certainly in healthcare, it's all been a good thing. But here's the downside, that President Biden can undo it all.
Right.
I don't think he will. Because a lot of things we're now talking about are very popular,
Right.
And so they'll be very slow to make big changes in healthcare. But the point is, he can if he wants to, and any future president could. And what we need to do is have it part of the law, so it's a permanent feature of this all has to do with the tax law, by the way.
Right.
Employer payment of health insurance premiums is not taxable to the employee. So that's a nice tax benefit. And the way the law is structured now is you get the same tax benefit even though the employee owns the insurance and can take it with him.
By the way, we're on the topic of healthcare in general. I do encourage people to get a copy of the book New Way to Care, just published by the Independent Institute. This is my marked up copy, but in the very back, there's this wonderful chapter on why Medicare for all really can't work, and I encourage people to take a look at John's observations on that topic when you get the book in your hands. Do you want to say anything about disability insurance, John, before we move on to solutions?
Well, it turns out that it's a bit of a racket, and people who are unemployed sometimes use the disability insurance as a way to continue to be unemployed and get a check from the government. And so we have a system that encourages people to fake their disability, is another way of saying this.
Yeah, right.
Or to exaggerate their disability. And we have a system that's weighed in favor of this kind of gaming. Now, down in Chile, it's a totally different deal. In Chile, they have a disability system. The worker, you have an insurance company, you have a worker who claims a disability. They can have a hearing. The insurance company can challenge the claim, and then it's settled. And once it's settled, the individual gets a check or a series of checks over time, but he can go right back to work. Now, in the United States, if you're getting disability checks and you're caught working, then you've violated the law and you can be penalized and fined. Down in Chile, they want you to go back to work.
I was going to say it's a perverse incentive otherwise.
Exactly. So maybe it's not quite the same kind of work. Maybe it's a desk job instead of lifting heavy things. But in Chile, once you resolve the claim, the employee gets either one lump sum check or a series of checks over time.
But it's settled.
It's settled, and they want you to go back to work. I mean, it's good for the economy to have people work. And their costs are half what disability costs in the United States and in Europe. Half.
Wow. And so much more favorable to the employee because you don't have to go with uncertainty. You don't have the sort of Damocles hanging over your head if you happen to earn some income. Everybody's better off.
Right. If you get caught playing ball with your kid in the yard and they say, wait a minute, you told us you didn't have that arm motion. Now we know you do.
Right. It's over. It's over. Well,
Yes.
The comparison with other countries is an extremely interesting part of your book. And, going back to Social Security, I think many Americans have finally come to realize that Social Security is not a system whereby you invest in an account and then draw from it later. Instead, it's a system whereby, if I've got this right, John, that we all get money taken out of our paychecks every week, and then that money then gets transmitted to current retirees. And it was all predicated on a kind of sense of the demographics back in the 1930s, where people were going to die earlier. And now doesn't look so hot, does it?
When we passed Social Security, I think the lifespan of an average American was about 62 years. And now we're in the 80s. So,
and that's great. We rejoice in that.
Yeah, it's a good thing. Bad for the finances of Social Security. And you're right. The kind of system we have is called pay-as-you-go. And pay-as-you-go means every dollar we collect in payroll taxes, we pay out in benefits. And it goes in and out the door the very day, the very hour, the very minute that we collect the payroll taxes. So there's no money's being saved. There's no fund of real assets for the future. So so thinking, 10, 20, 30 years down the road, as more and more benefits are accrued and the cost of the system grows, we're going to need higher taxes, or we're going to have to give people less than what we promised. So pay-as-you-go system is like a Ponzi scheme. It's like what Bernie Madoff went to prison for. And in fact, if the Social Security trustees were private trustees, they'd be in prison too, because this is a Ponzi scheme. We're collecting money and promising benefits, and we don't have the money to pay those benefits. We know right now that there's a huge gap between what's going to come in and what we're going to have to pay out.
Well, see, this is where the John Goodman solution gets really interesting and pretty novel, because a lot of people say, oh, well, yeah, we kind of know that's a problem, but if we just, cut off the whole thing, we're going to cut people off. They won't have their benefits. It'll just be horrible. But you have some solutions that can transition us almost seamlessly, at least over enough time, from this crazy system to a far sounder one. How would that work, John?
Well, we let young people have their own private account, and it would be invested conservatively, and it would build up over time and replace Social Security. And it looks like we can do that so long as young people pay a 4% tax to the system, and that buys out.
Mm-hmm.
And then their Social Security tax is about 12.5%, and so the rest of that they could put in private savings.
Mm-hmm.
And 30 by the beginning of this century, the 21st century, about 30 countries had completely or partially privatized their Social Security system in that way,
Mm-hmm.
or in a way that's similar to what I just described. Singapore is interesting. Singapore has never had any of the welfare state institutions that we have and that
Mm-hmm.
European countries have, but Singapore has forced savings. You have to save in Singapore. And Singapore has more millionaires per capita than any country in the world. 17% of the people in Singapore are millionaires.
17%?
Yeah, because of the forced
Wow.
savings, yes.
That's quite remarkable. Okay, I'm just going to pause for a little reminder to everybody who's with us today that, in fact, this is for our Lighthouse members, and I got a bunch of you on the webinar already. We would love to let you talk directly to John Goodman. A couple of you put up your hands at the beginning, and we weren't quite ready. I encourage you, if you've got a question or comment from John Goodman, click that little raise your hand button, and I'll get you online here. Also, you can type your question in the Q&A or the chat, and I will capture those too. So that's how we would gradually move out of the untenable Social Security system. What about moving back toward a more tenable health insurance system? You've got some solutions there too.
Well, let's take Medicare.
Okay.
That's much harder to privatize than Social Security.
Yeah.
Because Social Security, you pay in, it's a percent of what you're earning. And then at the other end, your benefits are a percent of what you
Mm-hmm.
have earned. So that's easier to do. Medicare is different. We are paying in a percent of what we earn, but at the other end, medical expenses aren't geared to what we earn
Right. Mm-hmm.
as a worker. So that's harder to do. But we found a way to do it, and my colleagues down at Texas A&M and I worked through the math, and we found that for about 4% of wages. Over a work life, workers can accumulate enough to pay for their medical benefits during their retirement years. And I didn't say earlier, but I think that it needs to be clear, and this is a mistake the Bush administration made. We need to have a rule that no one loses, so that so if it's Social Security, your savings are invested, but you never get less than what you would have gotten under the old system. And the same thing has got to be true for Medicare.
That's like the political genius of it, because
Yes.
you put in motion a transition toward actually funded care, but giving people that reassurance that it won't be less than it would have been, their benefit.
Right, and I think we had in our Medicare proposal that if you want, you can go back to Medicare. We don't expect that anybody would do that, but it's a sort of a reassurance, that no one's going to lose under this deal.
Mm-hmm. Yeah, and if they feel that reassurance, then they're much more likely to opt for or support politicians who opt for a solution that will be long-term viable rather than long-term non-viable. Nobody wants the thing to crash, later in the future. But on the other hand, they don't want to jeopardize their own shorter-term future. Your solution gives a way out and puts the system on sort of the path to recovery. It's like a 12-step process for Medicare and Social Security designed by John Goodman.
And I'm convinced the reason George W. didn't make any progress with his attempt to privatize Social Security was he didn't make that guarantee. And I talked to some Democrats who said, oh, you mean if it could be guaranteed, that sounds pretty good to me. So
Yeah, right.
he just never understood it, and the people around him, I think, gave him bad advice, quite frankly.
Yeah. Okay. Well, during, of course, the Obama years, they weren't very receptive to these ideas at all. Of course, Obamacare was really designed to be in lieu of these kind of solutions. But it's not working out so well, is it, John?
Obamacare is a mess. And the premiums are twice what they were when we started. The deductible on an average plan in Obamacare is 3 times what it is in a typical employer plan. And there's been a race to the bottom in terms of access to the best doctors and the best hospitals. I live in Dallas. UT Southwestern Medical School is probably the best research facility in the whole world for healthcare. But you cannot get in there with an Obamacare insurance policy. And down in Houston, MD Anderson Cancer Center is one of the top centers in the country. They won't take you either. So in terms of quality and access, we've made things worse for people with pre-existing conditions. You keep hearing about how we protected people who have a pre-existing condition. No, we made things worse because before there was Obamacare in Texas, let's say you had cancer and you were just rejected by private insurers, well, then you could go into the Texas risk pool and you would pay a bit more for your insurance, but the insurance was a standard Blue Cross plan that would cover just about any hospital, any doctor, and you would have been in much better shape than you are today.
Yeah, wow. Let's think about the current politics of this. I think there's a couple of questions about to come through from our participants, but I'm thinking about the new climate under the Biden administration. Obviously, the Obama-Biden team put Obamacare in place, and I'm sure that President Biden will be very protective of it. But on the other hand, I also wonder whether there might not be some new receptivity to different solutions. Do you see any reason for optimism that the Biden team or the Biden coalition might be receptive to some kind of tweaks, at least in the right direction?
Yes, I do. And the reason is because they know it's a mess. We have 30 million people who are uninsured right now. I think there's something like 8 million of them would qualify for a subsidy in the Obamacare exchange, and they're not buying. So we have a problem. And I did not mention earlier that in the unsubsidized part of the market, which is about 40% of the market, we're in a death spiral. And between 2016, 2019, the number of people in that part of the market where you don't get any subsidies has declined. It's almost been cut in half. And so people who are healthy are bailing out. So they've got a real problem. Now, what we're suggesting is that you look to Medicare Advantage. We actually have 2 systems in this country where people make an annual choice of plans. The plans compete. There's no discrimination based on health status. One's called Medicare Advantage. The other's called Obamacare. Mm-hmm. One works, the other doesn't.
Well.
Right. So what we're saying, look, let's take the things that work so well in the Medicare Advantage program, which again was created by Republicans, and use those ideas to reform Obamacare, which was created by Democrats. And I see that as a way to bring the 2 parties together, and we get bipartisan reform of Obamacare.
So the elements of your program that might appeal to the Biden coalition depend, at least initially, in the fact that there's a train wreck coming and everybody knows it. So something has to be considered. And probably the other elements of the appeal of your program, your solution package to the Biden coalition is that, in fact, people would have the ability to make voluntary decisions to opt in or not to opt in to some of these transitional programs. Would that be appealing to the Obama group, the Biden group? Sorry.
Yes. Now, I wouldn't use the word train wreck because this can limp along.
Yeah.
I mean, it's bad insurance, but not train wreck is too strong. It's just bad insurance. And if you have a way to make the system work better, everybody gains. And in Medicare Advantage, the plans can specialize. You can have a plan that specializes in diabetes. You can have lung care, heart care. And you can have centers of excellence. You can get really good at something. You can't do that in Obamacare. The plans have to be all things to all patients, and you can't specialize. You can't ask health questions. You can't asked to see medical records. And so, again, one system is working pretty well and it gets the right patients in the right plans. The other one's not working well.
I've seen a lot of stories of people who were trying to get coverage under Obamacare, but they had pre-existing conditions and they got dropped out of coverage. This is more common than people realize. It's a little ironic because a lot of people support Obamacare because they say, well, without Obamacare, pre-existing conditions won't be covered. Can you address that whole tangle?
Well, what happens is they drop the doctor you need. They drop the medical facility, the hospital that you need. So if you were here in Dallas, for example, and you had a rare condition, maybe the only place where you can really get it treated well is over at UT Southwestern, but you can't go over there. They don't cover UT Southwestern. So the best doctors are excluded, the best hospitals, Mayo Clinic is excluded, Cleveland Clinic. And
for example, you may be, I know some people are in this situation, you may be in a pattern of care, a program of care with certain facilities and certain physicians, and suddenly you can't access them anymore, and you have to start from scratch if you can even start.
Right. Now think about what's happening. The buyer, the enrollee, gets to make a decision once a year and has to stick with that decision. But the plan can change its network any day it wants to. So for the next 365 days, they can change their list of providers anytime they want to. So this is totally asymmetric, and the buyer has to commit, the seller isn't committing to anything.
Some people might say, oh, well, the solution to that is easy. We need to clamp down on the sellers just as much as we clamp down on the buyers. If the government controlled every decision, it would be totally fair.
Well, if government tried to control every decision, it would be even more of a mess than it is right now. What we want market incentives. We want a market that works. And to make sure that it works, let's take Cancer Treatment Centers of America, which is not in any Obamacare exchange. They should be able to come into the exchange. They should be able to say, we specialize in cancer. If you don't have cancer, you can't be in our plan. And if you want to be in our plan, we want to see your medical records. We're going to ask health questions. And yeah, we care about your health condition. But then Cancer Treatment Centers of America needs to get a premium that is fair, that reflects the cost of care. And right now, it probably wouldn't. And what I see happening in the Obamacare market is they're trying to track the healthy and run away from the sick. And the way you run away from the sick is the way you described earlier. We don't cover the expensive doctor, the expensive hospital, or really the care that you need.
Yeah, or that you may be in the middle of getting when they decide to opt out. One thing that I'm struck by as you talk about this, and as I've looked at your book, John, is that while many have called for what they call a single payer, I think it seems like one way of summarizing your program or part of it is that instead of a single payer, you seem to be advocating a single market. Am I right about that?
Well, we need a real market.
Yeah, a real market.
And if you want people to not be burdened because they have a health condition, then you need to have a risk adjuster that's adding on to their premium so that the premium the plan receives is a fair premium. So if we want plans to specialize in diabetes and do a really good job of that, then the plans have to receive a fair premium to do that. And that's not happening right now.
People have been limited in their ability to buy plans across state lines or just to sell them across state lines. Is that true?
Yes, but I don't want to make a big deal of that because the insurers are crossing the state line to get to the patients.
Sure.
And the benefits are more or less written into federal law. So what we really need to do is we need to have a real market where plans can specialize and get really good and become focus factories for various diseases. We need to have a market for sick people, and we need to have competition in that market. And plans need to be able to specialize. If you think about it, when you walk through an airport, you see these food courts, and you have Chinese food here, Italian food there, hamburgers here. Imagine if you told every one of those outfits, you can't specialize. You have to provide all those different kinds of foods at your establishment. Well, you'd have a big mess, right? And it would all be mediocre.
It would all be awful.
Yeah, that's what's happening in the Obamacare market. And it's different from the Medicare Advantage market.
Very illuminating example, John. I mean, I want to go to that, that taco place every time, but if if all they had was like some kind of taco burger Chinese something or other mixture, it would be no good. That's for sure.
I wasn't imagining it would all have to be mixed, but imagine you said to each one of them, you have to serve all those different kinds of food.
Or that, yeah.
They would do a mediocre job of everything.
Yeah, exactly. That would be terrible. Okay, so let me remind our friends on the line that you can, in fact, send your questions in here. Okay, here's a question from Terry. Do some healthcare providers do a much better job of providing healthcare? I'm with Kaiser and see that as a unique provider. Any comments? I don't know if you're in a position to comment, but can you?
Well, not so much on Kaiser, but of course some are better than others.
Mm-hmm.
And what I've always wanted is a real market. And in a real market, you have quality competition and you have price competition. So if you look at the market for cosmetic surgery or the market for LASIK surgery, that's the kind of competition you see. Now, what we have in the rest of the healthcare system is a system dominated by third-party payers who are making deals with providers. And what happens is when providers don't compete on price, they don't compete on quality either. So it's very hard to tell what kind of quality you're buying.
Yeah, that's very, very interesting point. I mean, it seems like the ideal thing would be, as in so many areas of economics, that when a market operates with relatively unfettered, scope, then the desire of providers or sellers to make a profit can be linked to the need of the customers to purchase the service. And that ultimately what we want people to be able to make money healing the sick.
Yes.
Because if they can make money healing the sick, then a lot more sick people are going to be healed.
Exactly. Now, I think Cancer Treatment Centers of America is a good example of this. Most of you all have seen them advertising on TV. They're just not in the Obamacare market. Mm-hmm. But that's the kind of thing that ought to be present in the individual market all across the country.
Remember, those on the line with us, that you are free both to type in a question in the chat box or the Q&A, or even better, just click raise your hand and I'll let you talk to John Goodman. Here's a question from a friend in Texas. Why do Republicans do such a poor job on the health care issue? Is that a fair question even, John?
Oh, that's a really good question. And the answer is because they don't want to spend time learning about it.
Republicans don't.
Democrats don't know much about it either, but Democrats have a good second sense about them. They know how to promise benefits even though they don't understand how it's going to work. Republicans are afraid of the whole subject, and not only do they not want to talk about health care, they never had hearings on Obamacare.
I mean, they had 2 full years when they had the majority in both the House and the Senate. And the presidency.
Yeah. So they could have just, they didn't have the House last year, but they had the Senate. They could have had hearings on what's wrong with Obamacare. They never had any hearings. There are many tragic examples of patients who have been abused and mistreated. They should be brought in.
They could have featured them. They could have featured those people. Mm-hmm.
They never did it. Boy, if it had been turned around, if Obamacare were a Republican plan and the Democrats controlled the committees, they'd be having a hearing every week.
Mm-hmm. Yeah, I mean, in fact, this is hypothetically thinking, but let's say that some of these more marketized reforms that you're advocating were adopted, and people were opting into the fully funded, privately owned coverage plans. And then there were some stories came out how people, weren't getting the care they needed and so forth. Those would be featured by the opponents of a newly liberated system. So in reverse, it would be featured. The answer to that, I think, if I'm following John Goodman correctly, is that those stories would be kept to a minimum if these reforms were adopted, because you already built into them the clarification that their benefits would be no less than they would have been.
When you have a real market, producers and sellers in a real market don't want bad outcomes.
Right.
And they don't want to read in the newspaper about bad outcomes. They don't want to go on the internet and see where patients are complaining about how they were treated.
It's bad for their reputation in the market.
Absolutely. It's just like a restaurant. You don't want to see on the internet people saying the food was bad, the service was bad. It was a horrible place to go. uh, that's the way competition works. You you do well when your customers like what you're doing for them.
Mm-hmm. Exactly. I mean, the thing is that if customers are unhappy, then you won't make money. I'm afraid that under the current system, there's at least an incentive or a tendency for healthcare and other providers to be more concerned, or at least as concerned, about satisfying federal regulators as about satisfying their customers.
Well, it's a bureaucracy, and the plans that have succeeded in Obamacare look like Medicaid. They look like Medicaid with a high deductible. In fact, the most successful insurer in the whole country in Obamacare, with 1/5 of all the plans, is a company called Centene. And Centene started out as a Medicaid contractor. It pays doctors Medicaid rates. And now, if you think about it from a doctor's point of view, the last patient you want to see is the one paying Medicaid rates. So if you have a choice, you'll take, Blue Cross first, private insurance, then maybe Medicare. And the last patient you want to see is the patient paying you the least amount of money. So they're not anxious to compete for those kind of patients.
And did Centene figure out how to navigate that, are you saying?
Well, Centene made money as what a Medicaid contractor is most people don't know this. Most people think Medicaid's a government program. In fact, 2/3 of all the Medicaid patients in the country are actually in private plans. So you have private insurers managing the plans, but the way they manage it is they're a monopoly. They're not competing against anybody else. And so if patients are unhappy with how they're treated, there's no place else for them to go. And so they can put their complaints on the internet if they want to, but it's not going to affect anyone's behavior.
Here's a question coming from one of our friends in Northern California. Says, I speak to many folks who see healthcare as a right. I try to bring them to the reality that it is a form of slavery. Well, I don't know if I agree with that, but anyway, that's what this friend says. Any good arguments that work better against the claim that healthcare is a right?
Yes, that's just rhetoric. It's what the Canadians say. It's what the British say. But is it really a right in Canada? If I'm in Canada, do I have a right to an MRI scan? If I'm the 100th person waiting in line, do I have a right to the 100th scan? No, I don't. Other people can and do get ahead of me. Even Americans can get ahead of me. So what does it mean to say I have a right to care? If Americans can go up there and pay out of pocket something I as a Canadian can't do, so the politicians telling me I have a right, but it's all rhetoric. It doesn't mean anything. I don't really have any enforceable right. I don't have a right to any particular kind of care.
I mean, if I was the 101st patient in that scenario and I was denied care in Canada, I couldn't go to the courts and sue for my right to the 101st slot in the MRI. That's not how it works. It can't work that way.
That's right. Which is another way of saying is you don't really have a right at all. You have the right to stand in line, but other people can, again, get ahead of you, and politicians do jump the queue, and powerful rich people jump the queue. And again, last time I looked, even Americans could go jump the queue. And if that's what you mean by a right to health care, that's sort of a meaningless phrase.
Yeah, it really is. I mean, the idea of a right, people like to use that term, I think, because it implies kind of a hard edge of enforceability. Like, I really mean this, so I'm saying it's a right. But actually, couldn't we, John, talk about the fact that it's desirable for everyone to have the best health care possible? Isn't that what we really want, as opposed to right? We want people to have widely available, good health care. That's our goal. Forget the right thing.
Well, I like the way you phrased it. We want, the way I would say is we want the healthcare market to work like other markets work, where people on the provider side compete to meet our needs. And we should be able to make decisions. And we may not want all the care that the medical profession can give us. We may decide that too much care is not always ideal. But so that's why I believe patients should control more of the dollars and make more of their own decisions.
A real functioning market. One of the reasons why I want to to see a real functioning market in all these social safety net areas is because I think it serves the common good most effectively. Markets are a means to the end, in my mind, of serving the common good most effectively. We all should desire the common good. I think that's good. The fact is that usually achieving the conditions that the common good requires are not best done through government controlled programs, but through functioning markets. That's how you can serve the common good. And even the people who are least advantaged economically, the poorest of the poor, are much better served in marketized conditions than in government controlled ones.
Yes, see, I can say I have a right to food. And how do I enforce my right? I go into the market and I buy it.
Right.
The government can't stop me from buying food. So that's the way healthcare should work.
Yeah, exactly. Beautifully stated, John. We are coming to the end of our time here. I am so grateful for the work that John Goodman has done on this book, A New Way to Care, Social Protections That Put Families First. I encourage everybody on the line, if you aren't already one of our Lighthouse members and getting it in the mail just as a membership benefit, to go to Amazon.com or to independent.org and order your copy. Talk about it with your friends. If you want more resources, you can go to our website, independent.org, and there's information on healthcare and on John Goodman's book. Of course, the Goodman Institute itself has resources. What's your web address, John?
GoodmanInstitute.org.
Hey, that's pretty simple. Yeah, we invite you to go there too. And we're so grateful for the people on this briefing call who really, your donations make it possible in order to get the word out about how, in my terms, how to serve the common good through truly free and functioning markets. That's not a popular message, and your support makes that possible. So thank you all for being members of our Lighthouse Society. Those of you who aren't yet members, we invite you to join us. Visit independent.org and get on our team for the future. Okay, so John Goodman, thank you again.
Glad to be with you.
I wish you all the best success. I hope you're super persuasive. I hope you get more, hearings before Congress. I hope the Obama team reads your book and that your bipartisan idea makes a breakthrough.
Thank you.
Okay. Thanks, everybody. We wish you all the best and join us next time for a Lighthouse Briefing from the Independent Institute. Take care. Bye, everybody.